Hi everyone, my name is Elizabeth Bonachea, and I'm an assistant professor of pediatrics at Nationwide Children's Hospital and The Ohio State University in Columbus, Ohio. This program discusses persistent pulmonary hypertension of the newborn, which we will refer to as PPHN. It includes 4 modules covering the normal fetal circulation, the pathogenesis of PPHN, the diagnostic features of PPHN, and the management of PPHN. This module will provide an overview of the normal fetal circulation. By the completion of this module, the learner should be able to describe normal fetal circulation and outline the process of transition from fetal to newborn circulation. Pulmonary vascular development will be covered in detail in the program on lung embryology, but we will review the key features. Recall that lung development is generally described as consisting of 5 phases: embryonic, pseudoglandular, canalicular, saccular, and alveolar. During the embryonic phase, the branchial arches are developing, with pulmonary vasculature arising from the 6th aortic arch and forming a vascular plexus in the lung mesenchyme. This can be seen in the figure colored in blue. In the pseudoglandular stage, the arteries grow along with the airways in a progressive branching pattern that, by the end of the phase, will resemble the adult patterning. Capillary structures mature in the canalicular phase. To understand the fetal circulation, it's best to review the normal adult cardiopulmonary circulation. In the adult, blood flows through a single circuit in series. The blood flow returns from the body to the right heart, passes to the lungs to be oxygenated, and returns to the left heart before leaving to the body. In this manner, the ratio of pulmonary blood flow is equal to systemic blood flow, a relationship that can be described by the ratio between QP and QS, where Q represents flow, P represents pulmonary circulation, and S represents systemic circulation. So in the normal cardiopulmonary circulation, the ratio between QP and QS is 1. As we will see in both fetal circulation and in persistent pulmonary hypertension, QP can be significantly lower than QS. During fetal life, the placenta, rather than the lungs, serves as the organ of gas exchange. The placenta is a very low resistance organ, whereas in fetal life, the lungs have very high vascular resistance. Only 10 to 20% of the combined cardiac output enters the pulmonary vascular bed in fetal life. Even though the surface area of the pulmonary vascular bed increases throughout fetal life, pulmonary vascular resistance also increases with gestational age. Multiple pathways appear to be involved in maintaining high pulmonary vascular tone prior to birth. The lungs are fluid-filled rather than air-filled, which exerts significant pressure on the developing vasculature. Pulmonary vasoconstrictors in the normal fetus include low oxygen tension, leukotrienes, serotonin, and Rho kinase. Vasoconstriction is also the result of low baseline production of endogenous nitric oxide and prostacyclin. Let's review the way the intracardiac and extracardiac shunts function during normal fetal circulation. In the fetus, oxygenated blood from the placenta travels through the umbilical vein to the ductus venosus and then enters the IVC. Blood flow entering the right atrium from the IVC preferentially streams across the foraminal valley into the left atrium. This preferential streaming ensures that blood going to the fetal brain and coronaries is highly oxygenated. The remainder of the IVC flow and flow from the SVC moves from right atrium to right ventricle to pulmonary artery. The majority of the blood entering the pulmonary artery shunts across the ductus arteriosus to the aortic arch, thereby bypassing the lungs. In summary, the fetal circulation is characterized by very low QP to QS ratio, a state which must switch to a QP-QS ratio of 1 during healthy transition after birth. During normal transition, significant change occurs in the pulmonary and systemic circulations. First, the lungs change from fluid to air-filled in a process elaborated in the fetal lung fluid program. The lungs mechanically expand with the first breath, and with cord clamping, the low-resistance placenta is removed, leading to a rapid escalation in systemic vascular resistance. At birth, there is a rapid decrease in pulmonary vascular resistance, which redirects half of the combined ventricular output to the lungs, increasing pulmonary blood flow by 8 to 10-fold. PVR will continue to follow the first several months of life until it reaches the low levels seen in adults. The increase in systemic vascular resistance and in pulmonary blood flow lead to increased left atrial pressure. Increased left atrial pressure leads to a functional closure of the foraminal valley. As pulmonary vascular resistance falls below SVR, blood flow through the patent ductus arteriosus reverses, where flow in that fetal life traveled right to left across the duct and now flows left to right. In healthy term patients, the ductus arteriosus functionally closes within 48 hours of birth, largely because of increased oxygen tension in the newborn. These two functional changes effectively separate the pulmonary and systemic circulations and establishes normal circulatory patterns. The most critical signals for the transitional changes in the pulmonary vasculature are mechanical expansion of the lungs, a drop in carbon dioxide tension, and an increase in oxygen tension. The fetus prepares for the in utero to ex utero transition late in gestation by increasing pulmonary vascular expression of nitric oxide synthases and soluble guanylate cyclase. The prostacyclin pathway is also important. Cyclooxygenase expression is upregulated in late gestation and is the rate-limiting enzyme that generates prostacyclin from arachidonic acid. Both cyclic GMP and cyclic AMP lead to vasorelaxation and vasodilation through a decrease in intracellular calcium. In this module, we reviewed the normal fetal circulation and the process of transition from fetal to newborn circulation.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.